Good afternoon, everyone. My name is Dr. Ghazi. I'm the microbiology consultant at Imperial College Healthcare NHS Trust. I would like to thank the Royal College of Pathologists for giving me the chance to talk to you today about the management of multi-drug resistant gram-negative bloodstream infection. My talk will be concentrating on the following. I will start with the case history, and then I will talk about classification of multi-drug resistant gram-negative bacteria, then the challenges in treating these infections, and how to manage these cases, and I will talk about the novel antibiotics which can be used in treating gram-negative, multi-drug resistant gram-negative infections. I will start with the case, which is a 61-year-old man who has a background history of deceased kidney transplant in November 2018, who has significant stenosis and stent. The transplant renal artery has stenosis, and it was stented in March 2021. This patient has a background history of end-stage renal failure due to diabetes. He has started on hemodialysis at Norfolk Park Hospital between 2013 and 2018. He also has retinopathy, which was treated with laser photocoagulation. He has a history of subtotal parathyroidectomy. He was admitted to the hospital with history of shortness of breath, which got worse over the last 3 days. He has history of dry cough, and his GP prescribed oral antibiotics, which was doxycycline, with no improvement. He also experienced retrosternal dull ache pain, which was consistent for the last 3 days, and the patient thought it is related to his chronic cough. He was passing urine, but continued to have to drink 1.5 to 2 liters per day. His salt intake was variable. He has no history of dysuria or hematuria. He has no graft pain. His chest shows bilateral basal crackles on the left more than on the right. Then his abdomen there was large incisional hernia, and it was non-tender, including the renal graft site. He has peripheral edema. So the plan was to add antibiotics to cover for community-acquired pneumonia with IV coamoxiclav. Chest X-ray was requested, ECG, and also added IV furosemide, and COVID swab was requested. The patient was treated as community-acquired pneumonia with fluid overload. So then his condition worsened, so he was admitted to intensive care, and this happened at the end of March. So he was started on tazocin, clarithromycin, and was treated with Septrin treatment dose. Clarithromycin interacts with his immunosuppressant, which is tacrolimus, so he was switched to azithromycin for covering atypical pneumonia. On 28th of April, he has rectal screening swab, which shows the following. The culture was positive for Citrobacter fungii, Klebsiella pneumoniae, and both isolates were OXA48 positive. So you can see in this slide the Citrobacter fungii sensitivity, and we can see that it was resistant to almost everything except amikacin, kefepime, fosfomycin, and meropenem. The sensitivity of the Klebsiella pneumoniae was even worse, so it was resistant to everything except the following: ciprofloxacin and meropenem. The patient continued to be at intensive care. He still required intensive care. So on 20th of May of the same admission, his blood culture grew the following: organism, which is Klebsiella pneumoniae, which is also OXA48 positive, and it has the same sensitivity as the rectal screening swab. So it was sensitive to ciprofloxacin and gentamicin, and also pifidicol, meropenem, and ceftazidime avi and tigecycline. So we treated the patients initially with high dose of meropenem, and this was the patient was not responding. However, so we switched him to ceftazidime avibactam, and the duration of treatment was 2 weeks from the date of negative culture, and lines were removed where the culture grew the same organism. So, what is antimicrobial resistance? Antimicrobial resistance is a complicated interaction between direct factors, which include misuse of antimicrobials in humans and agricultural animals, and indirect factors like environmental pollution, poor sanitation, and the innate characteristics of the bacteria themselves. So, antimicrobial resistance in developing countries is more likely to spread because of poor sanitation and lack of clean drinking water. So what are the factors that allow the spread of antimicrobial resistance? Cross-border transfer of patients carrying multi-drug resistant bacteria, and the transmission of multi-drug resistant pathogens in and between healthcare settings. Also, antimicrobial overuse and misuse, and inconsistent infection control practices. So MDRO are defined as microorganisms, which is predominantly bacteria that are resistant to one or more classes of antimicrobial agents that commonly used to treat these bacteria. These are usually resistant to penicillins, first, second, and third generation cephalosporins, and the implications of this multi-drug resistant organism are huge. So it gives associated with high cost, increased length of stay, higher mortality rate, lack of antibiotics to treat these infections, and the ability to cause outbreaks in hospital settings. This graph shows the classification of main beta-lactamases in Enterobacteriaceae, which is called as AMBLA classification. The AMBLA classification is classified the multi-drug resistant organism or the classes into 4 classes. Class A, which is usually beta-lactamases, and it is, as we can see, it is associated with penicillinases, and it is serine-based beta-lactamases. We can see that it is associated with ESBL, TEM, SHV, and CTXM, and for carbaminases, it is the KPC group. Class B is metallo-beta-lactamases, and it is associated with VEM, EMP, and NDM. The class C is cephalosporinosis, which is either non-inducible AMP-C or inducible AMP-C and derepressed AMP-C. The plasmid-mediated one is uncommon, while the class D is, as we can see, it is mainly the plasmid-mediated, and it caused the carbaminases CTXM group, mainly OXA48 group. This table shows the same classification, which shows which bacteria contains which class. So typical organisms producing beta-lactamases for the class A is usually E. coli, Klebsiella species, Enterobacter species, while class B, which is M, VEM, NDM, mainly in Klebsiella, E. coli, Klebsiella oxytoca, and Enterobacter species. The class C is cephalosporinosis, which is mainly AMP-C producing organisms, include Enterobacter, Citrobacter, Pseudomonas aeruginosa, and Serratia. And the class D is oxacillinasis, and it is oxa group, which include Klebsiella, E. coli, Citrobacter fungii, Proteus, and Acinetobacter pulmonale. I will talk a little bit about the English surveillance program for antimicrobial use and resistance, and this usually published every year. This report is published by the UK HSA, which is known previously as Public Health England. And we can see in this report that E. coli bloodstream infection is associated with high resistance rate to co-amoxiclav. It comes to up to 41.2%, and a significant increase in resistance to piperacillin, tazobactam, and carbapenems in 2021 in comparison with 2017. Then Klebsiella pneumoniae bloodstream infection, there's also increased resistance to cephalosporin, third generation cephalosporin, piperacillin with tazobactam. In 2021 in England, the carbapenems identified in gram-negative organisms are as follows, where OXA48 represents 41.8%, and the highest is in West Midlands. NGM is 25.1%, highest is in London, and KPC 24.5%, highest in Northwest region. In this report also, it shows this figure where it shows the number of confirmed non-big 5 unless in combination CPE isolates referred to the Public Health England, the Antimicrobial Resistance Reference Lab in 2021 compared to 2012. So we can see that the highest group of combination is the KPC OXA48 combination, followed by the OXA23. This is excluding the bloodstream infection. And since 2019, the reference lab are not taking any referrals from non-clinical samples. So hence the number of multi-drug resistant or the samples is very less in comparison with 2018. So this figure is also showing the number of confirmed CPE bloodstream infection referred to the Public Health England. Again, the highest number will be, this is the main groups. So we can see that the highest number is OXA48 plus KPC plus NGM. So these are the main groups. We can see in this figure that the highest is NDM plus OXA48, also KPC plus OXA48, KPC and NGM. Okay, next is the annual estimated total of the burden of antibiotic resistant bloodstream infection in England 2017 compared to 2021. We can see that from 2019, the number of multi-drug resistance is reduced, but the highest resistance rate is mainly in E. coli and Klebsiella. This figure shows the comparison between the Klebsiella pneumoniae bloodstream infection and E. coli, the resistance rate in relation to the main groups of antibiotics are used. So, for example, for the co-amoxiclav, we can see that this is very high in E. coli, while it is less in Klebsiella pneumoniae, but still both of them are highly resistant to co-amoxiclav, followed by the piperacillin tazobactam, where we can see that in Klebsiella pneumoniae, there is increased resistance rate in 2021 in comparison with 2017. And the third generation cephalosporin is also, there's marked increase in resistance rate. While in E. coli, the mainly resistance rate towards co-amoxiclav and ciprofloxacin. This map shows the distribution of the big 5 carbapenems producing organisms in England. And as we can see, when the color is darker, this means that it is high resistance rate. So we can see that the imp is concentrated in the north of England, while KPC is mainly in northwest, and NGM is mainly in London. OXA48 is mainly in Midlands, and VIM is in the northwest. And this shows the big 5 carbapenems all together. So next, this map shows the distribution of the 5 big carbapenesis producing organisms in the world. So we can see that the KPC is mainly in South Asia, America, and Canada, and also in South America, while also in Italy from Europe, while the NDM is mainly in India, Middle East. The OXA48 is mainly in Middle East and in England. So the mechanism of resistance for Enterobacteriaceae is caused by beta-lactamases, which is the main mechanism of resistance. There is an inducible chromosome encoded AMP-C cephalosporinosis, which is mainly in Enterobacter, Cetobacter, Meroganella, Serratia, and Providentia. AMP-C is strongly induced by amoxicillin, clavulanic acid, cefoxetine, and first-generation cephalosporins. Carbapenems are also potent inducer, but still active due to lack of significant AMP-C-mediated hydrolysis. Third-generation cephalosporin, while active, must be avoided because it will create high resistance rate by selecting resistant mutants, and mutation can lead to AMP-C overexpression, which is known as de-repression. The spread of this multi-drug resistance organism happens in healthcare-associated infection, mainly in Klebsiella and Enterobacter, and cause major outbreaks from 1990s. CTXM producing Enterobacteriaceae are highest in Southeast Asia and Middle East countries, and the carriage rate in intestinal carriage rate is 60% to 30% respectively. There is a plasmid-borne cephalosporinosis in Enterobacteriaceae, even in the community-acquired strains, and this led to the rise of ESBL and AMP-C, hence the increased uses of carbapenems, which led to the emergence of carbapenemase-producing organisms and development of resistance. AMP-C hyperproducing mutants are resistant to penicillins, aztreonam, third-generation cephalosporin, or even ertapenem. Imipenem and meropenem are the main beta-lactams which can treat these infections. Cefepime stands as a valuable carbapenem-sparing option, and plasmid-borne beta-lactamases are the most critical resistance issue in Enterobacteriaceae. Inhibitor-susceptible TEM and SHB penicillinases emerged first in 1960s. Mutation in the catalytic site enabled these variants to resist clavulinate or tazobactam-sparing cephalosporins. So the carbapenem resistance is increasing and mediated by acquired carbapeneses, predominantly by KPC, VEM, EMP, NDM, and OXA48-like types. Carbapenem resistant due to ASPL or AMP-C are usually combined with the porin loss. Porin loss conferred resistance to the new carbapenem beta-lactamase inhibitor. So outbreaks of carbapenemase-producing Enterobacteriaceae have been reported in the United States, which is mainly KPC, Southeast Asia, which is mainly NDM, and in Middle East, mainly OXA48, Brazil, and Colombia is KPC. What about the antimicrobial resistance in non-fermenting gram-negative bacteria like Pseudomonas? Pseudomonas aeruginosa has inducible AMP-C type cephalosporinases. Wild-type strains of Pseudomonas are resistant to amoxicillin with or without clavulinate, first-generation cephalosporin, second-generation cephalosporins, and they remain susceptible to ticagrelin, piperacillin, ceftazidime, cefepime, imipenem, etc. Unlike tazobactam, clavulinate is a strong inducer of AMP-C in Pseudomonas aeruginosa. AMP-C hyperproducing strains remain susceptible to carbapenems only. In Pseudomonas aeruginosa, carbapenem resistance occurs as a result of the porin loss or efflux pump or combination of the two. So this table or figure shows how to treat the multi-drug resistant organism I'm not going to go through this in details. However, you can see that if the patient has carbapenem-resistant Enterobacteriaceae, is it carbapenemase producing or not? And then we can have an idea which drugs we should be used. Also, if it is Pseudomonas and multidrug-resistant Acinetobacter, there's different protocols. This table is again shows us how to treat the ESBL Enterobacteriaceae and the Pseudomonas with difficult to treat, and this shows the different source of infection, if it is cystitis, pyelonephritis, or infection outside the urinary tract. What is the best treatment? And this guidelines is published by IGSA guidelines. Another graph shows how to treat and how we create our local policy for treating multi-resistant organisms, including metallo-beta-lactamases, class B, which is the hardest to treat, etc. This guideline was published, or this paper published recently in 2022 by a group of pharmacists, which was in order to give us idea about what is the pragmatic approach for treating antimicrobial resistance Enterobacteriaceae. So the principles of treating CPE infection, we have to start by management of these cases should be discussed with infection team, either microbiologists or infectious diseases, and the treatment should be started promptly without delay. Antimicrobial therapy should be guided with recent culture and sensitivities from the patient during the past 6 months. It should be started on suspicious of systemic infection and not on the basis of screening samples, and also it should be reviewed daily to check the response and possibility of de-escalation and the switch from IV to oral. Treatment should be tailored according to hepatic and renal function. Another guidelines were published by the BSAC, which is British Society for Antimicrobial Chemotherapy, and HIS, which is Healthcare Infection Society and British Infection Association Working Group. These guidelines were published in 2018 and also giving us a broad idea about how to treat patients with carbapenem-resistant organisms. I think this graph is really can be used easily, as it is showing us the risk factors for carbapenem-resistant organisms. If there's risk factors, so what should we do? There is no risk factor, so we should look at previous isolates and treat accordingly. If there's risk factors, so we should start by using either carbapenems or any of the novel agents according to the sensitivities. This paper is published into 2021, again, about the current and future perspectives in treatment of multi-drug resistance gram-negative infections. So I will start talking about the old and the new antibiotics which can be used in treating these carbapenem-resistant organisms or multi-drug resistant organisms. So the first group is the carbapenems. Carbapenems it's a group of antibiotics which have a penicillin-like mechanism inhibiting cell wall synthesis. They are active against most pathogens, but some resistance is emerging. It is active against Enterobacteriaceae when there is risk factors for ESBL, so we should guide carbapenem use, along with laboratory testing of susceptibility, particularly in severely ill patients. It's active against Pseudomonas. Main group is imipenem, meropenem, and doripenem. They are inherently active against Pseudomonas aeruginosa, but ertapenem is not active against it. Acinetobacter species, again, imipenem, meropenem, and doripenem were active. However, resistance is now widespread because of hospital-to-hospital spread of clones with oxacarbapenemesis. Ertapenem is not active against Acinetobacter. And the last group is Stenotyphomonas maltophilia, which is this species is resistant to all carbapenems of indigenous due to indigenous carbamidase production. Ertapenem is licensed to be used in Europe for the treatment of intra-abdominal and gynecological infections and community-acquired pneumonia. In the USA, it's also licensed for skin and skin structure infections for complicated UTI, for which it's widely used off-label in the UK. Meropenem are found to be narrowly superior to imipenem celestin. Celestin prevents the degradation of imipenem by urinary and ileal dehydropeptidase in both clinical and pathological outcomes. So actually, it is almost similar activity. Meropenem and imipenem has the same activity. For polymyxin, it is an old drug, which we don't suggest using polymyxin as a monotherapy because it is associated with high resistance and treatment failure rate. If we use it, we have to use it in combination with other drugs. Where colistin is prescribed for the treatment of an invasive CPE infection, it should be used in combination with one or more of other agents. Colistin therapeutic drug monitoring is recommended due to the high toxicity rate. Obviously, polymyxin is usually associated with neuropathy and nephropathy. Give careful consideration to use in higher doses regime, especially in critically ill patients. Use colistin with meropenem to treat susceptible KPC-producing Klebsiella species if the meropenem MIC is 8, and consider higher meropenem dose if the MIC more than 8 and less than 32. Consider colistin with aminoglycoside or tigecycline in patients with strains producing KPC or other carbamidase, which are susceptible to these but resistant to meropenem with MIC more than 32. Aztreonam is allyl to AMP-C and ESBL enzymes. It is stable for metallobeta-lactamases and OXA48-like carbamidase, but most Enterobacteriaceae with these enzymes are expressing ESBL or AMP-C, which confer resistance. And Aztreonam avibactam combination in phase 2 development. This creates a combination with very promising activity against Enterobacteriaceae with metallobeta-lactamases, OXA48, AMP-C, ESBL, and other beta-lactams. We shouldn't use Aztreonam alone empirically if multidrug resistant gram-negative, positive, gram-negative, or gram-positive or anaerobic pathogen are suspected. We shouldn't use Aztreonam for CTXM, ESBL, or AMP-C producing bacteria, even if it is susceptible in vitro. For fosfomycin use, it's first described or discovered in 1969. It inhibits the formation of peptidoglycan, so it is bactericidal, and its oral bioavailability of the fosfomycin to methamine salt is low. It's about 40%. For this reason, we only use fosfomycin in uncomplicated lower urinary tract infection, not in pyelonephritis. Fosfomycin is active against majority of ESBL producing Enterobacteriaceae, and fosfomycin is recommended to use in combination with other agents when used for systemic infection. In this case, we use fosfomycin IV. Kefepime has a higher failure rate in treatment of infection due to ESBL producing gram-negative infection. Kefepime can be used for treatment of infection caused by ESBL or AMP-C producing bacteria if susceptible. Kefepime shouldn't be used to treat infection with CPE. For Ceftazidime-Avi, the combination has a broad gram-negative activity, including Enterobacteriaceae and Pseudomonas. Ceftazidime susceptible bacteria usually remain susceptible to this combination. Avibactam protects additionally against class A, TAM, SHV, CTXM, KPC class C, which is AMP-C, and some class D, which is oxalate-beta-lactamases. Ceftazidime-Avi has no inhibitory activity against metallobeta-lactamases. It has activity against KPC2 and most OXA48 carbamylase producing strains. Ceftolozane tazobactam is an oxyminino cephalosporin that has been combined with tazobactam. Ceftolozane tazobactam is an active against many gram-negative organisms, including Enterobacteriaceae and Pseudomonas aeruginosa. It is active against Pseudomonas aeruginosa isolates that are resistant to standard agents. Ceftolozane tazobactam has potentially different uses than ceftazidime avibactam and shouldn't be used for infection due to AMC or KPC producing Enterobacteriaceae. It is licensed for complicated intra-abdominal infections and complicated urinary tract infection. It is not active against CPE strains, excepting ceftazidime susceptible OXA48 producers. It is used in combination with metronidazole. It is non-inferior to meropenem for intra-abdominal infection. It's non-inferior for to intravenous levofloxacin in complicated UTIs. It is the most active beta-lactam against Pseudomonas aeruginosa. Meropenem vapobactam. This vapobactam is a novel boron-based beta-lactamase inhibitor. This combination has enhanced activity against gram-negative organisms, particularly Enterobacteriaceae with class A and class C carbapenimases. Beta-lactam inhibitors are only active against some class A, SHB, TEM, Klebsiella, KPC enzymes, not active against class B or D. It is licensed to be used against complicated urinary tract infection, including pyelonephritis, complicated intra-abdominal infection, hospital-acquired infection, including VAP, bacteremia, including any of the above as a source of infection. Dose is usually 2 gram meropenem with 2 gram vapobactam infusion over 3 hours, giving 8 hourly. And dose should be adjusted according to renal function. Cefidricol is the first in its class, which is an injectable siderophore cephalosporin with potent in vitro activity against carbamylase producing organisms and drug-resistant non-fermenting gram-negative bacilli. Its unique mechanism of action allows the high intracellular penetration into the periplasmic space and increased stability to many beta-lactamases, including both serine type, KPC and OXA48, and ambler class metallo-beta-lactamases, VIM, EMP, and NDM. Cefidricol has an important place to play in complicated urinary tract infection, but further data are necessary to determine its place in therapy of other systemic infection, including pneumonia and bloodstream infections. It is considered for combination of therapy of invasive CPA infections, including class B, which is the first drug can be used in treating NDM, VIM, and EMP. It is approved for treatment of infection caused by aerobic gram-negative organisms in adults with limited treatment options. In the USA, it's also approved to be used in complicated urinary tract infection, including pyelonephritis, hospital-acquired pneumonia, and ventilator-associated pneumonia caused by susceptible gram-negative bacilli. We can see that how it works. It's combined with the iron, and then this allows the antibiotic to go into the cell and causing the mechanism, the action. So it inhibits the gram-negative bacterial cell wall. So it is bactericidal. The dose, again, should be reduced according to kidney function, and this you can see how much you can give according to different creatinine clearance. How to treat carbapenem-resistant Acinetobacter baumannii pneumonia? Colistin with combination of any of the carbapenems and adjunctive inhaled colistin therapy can be used for Acinetobacter baumannii multidrug-resistant bacteria. We do not recommend use of tigecycline as monotherapy for treatment of carbapenem-resistant Acinetobacter baumannii. Although colistin sulbactam or colistin tigecycline shows no in vitro synergy, there is no strong evidence that this combination is superior to monotherapy for the treatment of carbapenem-resistant Acinetobacter baumannii. What is the role of infection control and antimicrobial stewardship? Actually, it is a huge role of infection control and antimicrobial stewardship for treating these infections. We should have a comprehensive approach in order to identify the risk factors for carbapenem-resistant organism or multi-drug-resistant organism, early detection and identification of these organisms, implementation of infection control and prevention strategies to avoid the spread of the bacteria. The use of contact precautions. We should develop guidelines on how to identify these organisms in the lab. Should have a system with active surveillance, screening of the patients who has high risk factors for colonization with multi-drug resistant organisms, and then use antimicrobial stewardship program, which should be start smart, then focus, which means that we start the antibiotics in the right way, with the right time, in the right time, start as soon as possible, then review after 24 to 48 hours to see the response and the ability to switch from IV to oral. This is the most important part of treating these infections. UK HSA again put a framework to contain carbapenemase producing Enterobacteriaceae, which shows that we should screen high-risk group. We should apply surveillance to enable ongoing monitoring. We should have infection control practices and infection control precautions in place. We should have effective environmental cleaning and decontamination, has antimicrobial stewardship program, optimized laboratory methods, prompt recognition of outbreaks, and organizational ownership to support the implementation of this framework. As part of UKHSA, they managed to find that there's health inequalities associated with antibiotic resistance organisms and antimicrobial prescribing. So the AMR health inequalities work stream aims to reduce health inequalities, which shows that we should understand the association between healthcare inequalities and antimicrobial usage and resistance, learning from wider public health community and recommendation for the public health action. And actually, it was found that there are elements of inequalities, which include socioeconomic status, protected characteristics like age, sex, ethnicity, etc. Look at the vulnerable group, who are the people who are at high risk of developing, and the geography, which found that there is certain areas has a high rate of multi-drug resistant organisms. So in conclusion, the management of infection associated with carbapenem-resistant organisms remains a challenge for the clinicians and the infection team. Early identification and susceptibility testing are essential for prompt inhibition, for prompt initiation of effective antimicrobial treatment. Antimicrobial susceptibility testing and genotypic characterization of resistance is important, and drug-resistant gram-negative infections requires a comprehensive approach involving surveillance, infection prevention control measures, antimicrobial stewardship, and collaboration amongst the healthcare professionals. Thank you very much for listening. There's loads of reference at the end of my talk. I would like to thank you all for your listening, and I would like to thank the Royal College of Pathologists for giving me the chance. Thank you again.